Good afternoon and welcome everyone to the Global Men's Health panel and webinar. Thank you very much to those who have joined us in the audience here and those who are joining us online around the world as part of making this a joint panel and webinar discussion. We've got a really exciting period ahead as part of this event, and we're looking forward to the conversation and to thinking about moving the agenda on men and health forward. My name is Tim Shan from University College London, and we have a great panel of speakers with us today who I'll introduce in a moment. Beforehand, why should we focus on men and health within this conference? There has been discussion about the fact that in the field of gender and health more broadly, men's health needs have often been overlooked, and also there's been a lack of focus on how men's behaviours affect the well-being of others. We know also that dominant constructions of masculinities influence men's poor health-seeking and their risk-taking behaviour. In addition, we know that health systems are often insufficient in their attention to increasing men's access and to addressing men's health needs. And that in addressing these issues, it's good not only for men, but also for women and the public health system. So we want to have a conversation here today about these issues. In particular, how do we move forward? How do we address the challenges in the context of the men's health agenda, not only within the field of sexual reproductive health and HIV, but more broadly? And how do we ensure comprehensive programming so that we don't have programming for women and girls over here and programming for men and boys over there? How do we comprehensively address gender and health? The format for today's session will be an initial presentation on some of the global data and context to this issue. I will then have a conversation with our esteemed panelists, and then we'll open the floor to discussion here in the room and globally for those joining us online. For those online, there are two ways that you can get involved: through the join.me software and posing a question, and you can also send a Twitter message to #GenderSeminar. Let me introduce my panel. We have Gary Barker, who is the International Director and founder of Promundo, an international NGO with offices in Brazil, Rwanda, Burundi, Portugal, and the US that works nationally and globally in engaging men and boys for gender equality. He has led research and program development with men and boys in the Balkans, Brazil, South Asia, and Africa, Central America, the Caribbean, and the US, including in post-conflict settings. He is co-chair and co-founder of Men Engage, a global alliance of more than 400 NGOs and UN agencies working to engage men and boys in gender equality, and a member of the UN Secretary General's Men's Leaders Network to End Violence Against Women. To Gary's right is Eduardo Suarez Pecora, who is the coordinator of the National Men's Health Policy at the Ministry of Health in Brazil. He has a bachelor's degree in psychology from the University of Brasilia and a master's degree in health policy management from the University of Bologna in Italy. He has been acting as an independent psychotherapist since 1998, and for the last 17 years has focused his research in the areas of gender and masculinities. To Eduardo's right is Mikel Avni, who is the Senior Gender Advisor in the Office of Population and Reproductive Health at USAID Washington. She has over 20 years' experience of working to promote gender equality in the context of health. Mikel joined USAID in 1998 and has been working since to integrate gender into USAID's family planning and reproductive health programs. She has directed the office's portfolio to address women's empowerment, constructive engagement of men, prevention and response to gender-based violence, and the mitigation of child marriage. Mikel is also chair of the USAID Interagency Gender Working Group. She has an MPH degree from the University of Michigan School of Public Health, and before joining USAID, Mikel worked as a researcher in maternal health and gender. And finally, to my left is Sarah Hawkes, who is a reader in global health at University College London. where she leads a research group looking at the role of evidence in public policy processes. A specialist in sexual and reproductive health by training, Sarah has been researching the relative absence of men in SRH policy responses and programme interventions for more than 20 years. In the past few years, Sarah has conducted research on the relationships between gender norms and health, and has focused her research questions on trying to understand institutional responses to gender in the face of the evidence around men's health. Sarah works closely with the UN system at global and country levels, particularly in China, Iran, and Bangladesh. So let's get started. Firstly, Sarah's presentation.
All right, I'm going to just give you one quick definition for those of you that perhaps don't work in global health, which is a metric called the Disability Adjusted Life Years, which is an econometric measuring years of healthy life lost. And the purpose of this metric is that it's a global exercise, which up till fairly recently has been undertaken about every 10 years to really identify what the global burden of disease and risk behaviours and causes of mortality looks like. And the purpose of this enormous global exercise, which is coordinated out of the University of Washington, is really to help policymakers around the world, including funding agencies and norm-setting agencies and national governments, set priorities on the kinds of health issues that they should be responding to now and in the future. And what we've simply done in this slide is presented to you the top 10 DALYs globally in 2010. And I've been incredibly gender appropriate here and put boys in blue and girls in pink. And what you'll see, what you'll hopefully pick out from this slide immediately, is that for every single one of the top 10 DALYs, the top 10 burdens of disease around the world are all more burdensome in men than in women. And for road injury, what we see is that the burden is 3 times higher in men compared to women. The DALY burden, as I say, is a metric of disease itself, but obviously diseases arise in part because of the behaviours that we as human beings undertake. And so part of the DALY exercise is to look at what are the risk factors that lead to those DALY outcomes. And again, this is 10 risk factors for disease around the world. And again, you'll see that every single one of them is more burdensome in men than in women. And for 2 of those risk factors, smoking and alcohol, again, we see that the ratio is at the rate of about 3 to 1. When we look at what do people actually die from, this slide was published just a couple of months ago, and it looks at the kind of headline news that I'm sure that you're all aware of, which is that life expectancies are extending around the world. It's one of the great achievements of development over the past 40 years, is that we can all expect to live longer than our parents lived, and certainly longer than our grandparents lived. But if you look at where the biggest gains have been made, where you see the greatest reductions in age-specific mortality rates, oddly, the people who did this labelled the slides the wrong, what I think is the wrong way around gender-wise. So girls are in blue and boys are in pink in this slide. But what you'll notice is that the greatest reductions, the 50 to 60% reductions in age-specific mortality rates, are in women. The lowest reduction in age-specific mortality is in men. So the people who have gained least from that extension in life expectancy is men around the world. So we summarize this simply by saying that globally, men take more risks, men get sicker, men die younger. And it begs the question, how much of that is due to the difference down to biological sex, and how much of it is due to gender? And one way of looking at that question is to use the same DALY data. And this presents DALYs in the 0 to 4 age group, and it shows you something that we've known for decades, if not at least the past 100 years, which is that at birth, boys are biologically weaker than girls, which is one of the reasons why the natural sex ratio is in favor of boys, is because more boys are going to die from natural causes than girls do. And so what you see in this slide is some differences in mortality rates between boys and girls in the 0 to 4 age group, but not huge differences, not those 3 to 1 differences that we saw in the global adult population. What we see if we look at a slightly older age group, if we now start to look at what happens in adolescents and young adults, is that we start to see those big gaps come in. And those big gaps in DALY burdens in adolescence, I think, are very clearly now driven by behavior rather than by biological sex. So if we look at where the biggest ratio differences in the health of adolescents and young people is, it's in road injuries and in interpersonal violence, both of which predominantly affect young men. The young women in this age group are starting to suffer again from conditions that could be viewed from a gender lens. They start to become anxious, they become depressed, and they get nutritional disorders. So why do we see those gender differences? Well, the thing that the cause, I mean, there's lots of discussion about whether this is down to individual choice around who chooses to smoke, who chooses to drink. Is it down to social norms, the kind of discussion and discourse that you'll hear a lot about over the next 3 days? But the determinant that we think is most important when it comes to those really big differences in health between men and women is actually from the commercial sector, the commercial determinant of ill health. Tobacco, alcohol, and the road industry. We think that there's very clear evidence that these industries promote negative aspects of masculinity as a commercial strategy. But the final couple of slides are really to point out to you that essentially the world is changing. Gender norms are not static. Gender norms shift and change. And this is best summarized in something called the gender roles modernization hypothesis, which again has been around for at least 20 years and was again first described here in the US. Although I understand that even Engels wrote about this, although he didn't call it the gender roles modernization hypothesis, in 19th century Britain. It's the description that as women become empowered, as women become autonomous, as they gain agency, and importantly, as they gain access to financial resources, what women do is essentially they start to behave from a health perspective like men. So behaviors that had previously and are currently predominantly male behaviors in the future will become female behaviors as well. So if you look at this slide, and I'm just going to show you this one slide, which is from a huge survey that takes place every 4 years across the 40-odd countries of the European Union, and it's a survey that's done among 15 to 16-year-olds, 100,000 every 4 years, to look at risk-taking behaviours around drugs, alcohol, cigarettes. And what you have seen over the past 20 years is a complete narrowing of the gap in risk behaviours between boys and girls across the European Union. And certainly for smoking, we are now at a situation where boys and girls smoke at the same rate. And for alcohol, the gap has significantly lowered. Is that related to empowerment? Well, there's really only one study in the world that has tried to see whether, in fact, that hypothesis about women's empowerment and risk-taking is correct. And if you look at this slide, and I don't expect you to focus on the minutiae of it, but just Bangladesh and Sweden are placed. And what this slide shows you is that across the bottom, across the x-axis, as women become more empowered in a society, this is the national UNDP reported gender empowerment ratios, that the proportion of smokers amongst all smokers in that country, the proportion of smokers who are female rises in direct correlation as empowerment rises. So if you're in a country like Bangladesh, where women are clearly not very empowered at all, hardly any of the smokers in the country will be women. By the time you reach Sweden, which is the most gender equal society that we currently have in the world, women are smokers and men are smokers. So for me, this fits in very well with the idea that gender norms, which are currently adversely affecting men, will in the future adversely affect women in the same way. We're not the only people who've picked up on this. This is a direct set of quotes from the internal documents of the alcohol industry, specifically pointing out that they are going to target the untapped markets of Africa and Asia to sell alcohol. And there are very similar quotes from the cigarette industry too, showing that there are whole departments in those industries now targeting on selling alcohol and cigarettes to women across Asia and Africa. How does the global health institutions respond to this? Well, as you probably can guess from the way we set this up at the beginning, they respond to this whole phenomenon of all of the adverse, the majority of adverse behaviours currently situated in male risk-taking, men getting sicker, men dying younger. The whole focus of global health institutions is currently on women, and it's particularly on women and their reproductive health. And that's really across the board with global health institutions, except the Gates Foundation, which, despite weeks of trawling through their website, we were never able to find mention of gender once in any of their programs. I'm going to leave it there, actually, just as an introduction, a long introduction, for which I apologise, on the evidence of global health and gender.
Great, thanks very much, Sarah. So let's open up to the panel. Gary, if I could come to you first to reflect on what you've heard from Sarah. I know that Promundo has done a lot of work on men and health, generally, sometimes specifically within the context of sexual and reproductive health. What do you think are some of the barriers to advancing this work? And can you talk a little about Promundo's specific experience and reflections on this?
Sure. What I think if we see the macro a blind spot around men's health and men's vulnerabilities. Those things play out in the socialization of boys and girls every day. So you don't have to spend much time in a primary health care center in much of the global south. Basically, who one sees there are women and children. And if we shift that to the global north, where we do see more men showing up in primary care, it's typically older men. And typically, and again there's some data on this, typically accompanied by a female partner. That as men that we've interviewed have said, well, we see, our wives are kind of our ambassadors to our health care. So this duality that men's ethic of care is kind of a scarce thing. I think what we've tried to do as Promundo is to look at ways that we can question that. And I think it's fair to say that it's got to be it's kind of acts of desperation to figure out ways that we both change the demand side, to look at norm change so that men do see themselves as in need of health care, and that we also have to change the service delivery base. So one, and I've got a couple of pictures that I just thought I'd show because they show some of our acts of desperation. If you have those there, Tim. What am I doing? Louder. Okay, got it. Just wanted to show a few tried, and I say try, and then some of them that have succeeded, Eduardo's going to talk about because collaborations with the public health system. So one, this is a graffiti that we had painted on a municipal health post about 6-7 years ago. And it came out of a discussion with the adolescent health sector folks. So why don't young men come to clinics? And there was one, this fear of health providers, that young men in favelas are causers of harm and must prove often came in shorts and flip-flops. They were seen by a mostly female health staff as being dangerous and not really needing of health care. And so one simple thing, we worked with a graffiti artist to say, so what is it that we need men to have? And so this was actually painted, this thing was the whole wall of a clinic in a neighborhood called Bangui. And it basically says, guy, come on over, the place is for you. You come to a health clinic, you can ask questions, you can exchange ideas, and you can get condoms for free. Brazil's municipal health system or national health system has made condom availability for a very long time, but the real difficulty of getting young men to come in the door. The huge amount of need to work with the women in white, because virtually all the healthcare providers were women. So working the norms in their head as well. The next one. And I'll describe this next one. Actually, skip ahead now. I'm going to move around a little bit. That one. This was another one of who influences how young men go see healthcare. Mostly what we found is, again, that notion that women as the ambassadors for men's health. And for boys, it was mostly the mother. So this was an attempt in a brochure for mothers of kind of the care and feeding of your adolescent son. Kind of everything you needed to know about your boy. And the phrase here says, when a boy grows up, he thinks he can do it alone, but he needs help. And so again, having mothers be part of well, he just goes off by himself. He doesn't tell me what's going on. I don't know mentally or physically what's up with him. So engaging mothers as allies in the process. And then skip back to the other acts of desperation to get men to come to healthcare. This is a bit of trickery in this one, and this is setting up football leagues, and around the football leagues having messages about different things: HIV prevention, caring for your children, getting health checkups, gender-based violence, and providing jerseys, fields, water bottles, paying for some of the the kind of scorecard stuff, a broadsheet, all embedded in there while you're reading about the sports stuff, putting in their messages around health, gender-based violence issues. And the trickery was, if you came to the league and you wanted to be in you could play, you could get the jersey, you had access to the field. The next week we upped the cost. You have to come to a session this week where we're going to talk about relationships. So a bit of trickery that we think paid off, and we have some impact evaluation data, but I won't talk about. But we think that has paid off as an approach as well. And I think I have one more there, Tim. If you can pass for the end. Tim? Okay. Are you with me, Tim? Well, I'll move on. Another item that we think is really, really key is the work with health providers. A health system is only as good as the providers. and one of our colleagues, I'm not sure if he's here, from Chile, did a study. They actually did a survey of health providers, men and women, and asked them their views. Yeah, the last one I'll go into. Their views about gender roles. Health providers who had more rigid notions about gender, that women did the caregiving and men are the providers, etc., were less likely to talk to a man in the prenatal visits, or in general if there was a visit with a child. And those who had more equitable views were more likely to talk to the man and the woman if they came together with a child for a visit after the child was born or during a prenatal visit. So we know that, but this data sort of makes it obvious that what is in the heads of providers, the institutional norms about a clinic setting, and how individual healthcare workers, who are the front line of everything that we're trying to do in the healthcare sector, have to be worked as well. So whatever campaigning we might do to do norm change has to be as much in the community as it has to be inside. And the other that I'll leave, because Eduardo's going to talk a lot about it, is fatherhood as a point of entry for men, not only for their child's health, but also their partner's health. The next one, and making it a right. So again, this is part of an advocacy campaign that says you're not doing men a favor when he comes to the clinic by letting him come in. The woman has a right to have someone accompany him. Brazil's got that on the laws. You need to know about this. Let's make it clear that fathers aren't visitors, but let's also make it clear that the right to have him present resides with the woman. So again, I want to just leave that as an angle around the importance of saying we want to make sure as we bring men into some spaces, particularly sexual and reproductive health, maternal and child health, that we have a really strong no harm lens, do no harm lens that says this is not about his right there, this is about her right to have him present. So again, another strategy just to say how we also need to advocate from outside. We are mostly friends, but sometimes we have to do our nudge as civil society around these topics, and to make clear laws that are on the books. What is it that the health system needs to do to adequate itself so it's able to actually fulfill that right?
Great, thanks very much indeed, Gary. If I can move next to Michal. Michal, as I explained when I introduced you, you've been a champion of this work in terms of focusing on engaging men for many years, and in particular in the area of family planning and sexual and reproductive health. You've heard the data that Sarah has presented. How would you respond? Which issues do you think require greater attention and understanding?
I think these data aren't surprising, and I agree that cultural constructions of masculinity around the world do make boys and men sick, as your title suggests. They do exacerbate men's vulnerability, health conditions, both communicable and non-communicable diseases and injuries. I think looking at the data at that level, that global 30,000 feet up, is very valuable to give us a sense of sleep trends and maybe even help us kind of look beyond the horizon to what's coming. I also think that in some ways the picture is a bit more nuanced and complex, particularly from the vantage point where I come from, which is international family planning and reproductive health. In my area of work, for example, we know that in sexual and reproductive health, women and girls are disproportionately affected in some ways, and we saw this even in the data that you showed for by the time you kind of narrowed down to adolescents, it showed in prevention, suppression, especially in HIV. So for a range of biological and gender factors, girls and women are more vulnerable and suffer disproportionately from unintended pregnancies and the range of sequelae related to that, including unsafe abortion, sexual violence and intimate partner violence, the range of maternal complications and HIV. So I think what the data show is that, broadly speaking, across multiple health issues, we have fallen short on considering the unique health needs of men and on engaging them in disease prevention. And I think nowhere is that more true or more evident than in the field of global family planning. The field of population and international health, since its inception in modern days in the 1960s, has really revolved around beneficiaries and users. I think in part this focus on women is driven by a commitment to protect women's rights over their reproductive health and to ensure their agency and their ability to control their fertility and choose to use contraception. This is incredibly important and very central. But this focus on women, solely on women or primarily on women, I think is also the result of gender norms, beliefs, and biases that we have around family planning, and the belief that family planning is women's domain, that men are indifferent or disinterested when it comes to family planning, or worse yet, that they can't be trusted, or that they're even obstructive to women's reproductive health. This tremendous focus on women has actually come at an unintended cost of men's exclusion. And as a result, I think we've essentially built a subfield of public health in family planning, international family planning, and maternal and child health that frequently leaves out men. This is really unfortunate. We know around the world that boys and men lack accurate knowledge about their bodies, how their bodies function, and also about women's bodies. And that, of course, has an impact on reproductive health. We know that men hold lots of myths and misconceptions about family planning methods. So do women, but so do men, and that's significant because they often have more power in relationships. And we know that men are less likely to seek care and then to support this in their partners in seeking that reproductive or accessing reproductive health services. So I think, Jeannie asked what is it that we need. I think we need to improve our understanding of the associations between gender norms and social construction that affect health status, and make that research more routine so that it really informs our interventions in more effective ways.
Great, thank you very much. Eduardo, can I ask you, from the vantage point of someone who sits in the Ministry of Health and someone specifically looking at men's health within that, what do you think about this conversation, the figures that you've heard from Sarah? What are some of the lessons that you could share with us from your work on men's health?
Okay, good morning everybody. English is not my mother language, it's not my first, nor second or third language, so I try to do my best. I am here with my friend, my colleague Gary Barker, who is my official translator in this kind of case. So he's going to help me to do it in English, but I ask apologize and your patience. Well, these issues that Sarah are talking about are also reflected in the Brazilian national policy for integral health attention to men. No? In Brazil nowadays, men are living 7 years less on average than women. This is very important to share. Men in Brazil, like most places, they are afraid to discover diseases. They think they will never get sick and so do not care, not seek health services and do not follow the recommended treatment, are more exposed to traffic accidents and jury roads and work, doing the work either. They present specific vulnerabilities that contribute to an increased susceptibility to infection, STD and AIDS, like we know. They use alcohol and other drugs in larger quantities. Now in Brazil, we lost a life. Young men died last week because they were just in a university party with other guys. I don't know if you noticed this. And they were playing about drinking vodka, and this guy drank 30 doses, 30 couples, vodka couples, 30 shots, and he died. He had a respiratory break, and Hidayat. And this opening a very big discussion in Brazil about how the young people are drinking alcohol, and in Brazil is allowed. It's really serious. You can, a teenager can go in a supermarket and buy as much alcohol he wants. So it's really a serious problem. I'm involved in most situations of violence there, either. I have here, this computer help me. I need it. I do not exercise regularly. Oh, well, to be a man, when we are talking about the biological aspect and not making reference to the gender norms, we can say that to be a man is like to be a very big risk factor movement when we associate all these kind of things, no? When we are working about gender perspective, the things change because we can realize that we are talking about genders, we are talking about qualities. We are talking about ways of feeling, ways of living, ways of thinking, or ways of expressing yourself. So this is really important to separate the two fields, the biomedical field from the gender, social, historical field. Wow. It's very important. In Brazil, we are trying to do this, to connect these two fields, to work with gender norms. They are very powerful but soft technologies in the Brazil health national system, associating with the biomedical model, the way people work there. It's really important to understand how these principles, the principles feminine and masculine, they dance within us. This is really important. And this inner dance helps us to define what we call identity and to develop our own ways straight to healthier lifestyles or destructive styles that will contribute to several diseases, dysfunction, and early death many times. In Brazil, that's what happened. We are losing a lot of teenager lives every year by traffic accidents and for homicides. Tatiana Moro is expert on this issue in Brazil. So we are working there with what's the objective of the policy that I'm coordinating is to work nowadays. We have 5 pillars. We are working to facilitate and expand men's access to quality health actions and services in Brazil, recognize and effectively use the gender relations perspective in order to reduce morbidity and mortality and improve health conditions and well-being. We are making training, presential trainings and EAD trainings with all professionals, health professionals in Brazil. In Brazil, we have nowadays about 5,570 municipalities. It's a very large country. And nowadays, the policy, we have programs, we have actions from the mental health policy happening in about 1,000 municipalities. This is interesting. We are going slow because it's a lot to do. And nowadays we have been working over 5 pillars: access and embracement in primary health services. Promundo is our big partner when we are talking about the prenatal partner. It's really important. We are helping to bring more men to be together with their partners, their human during the birth, after the birth, and all this period. We are working with sexual and reproductive rights, either prevention of violence and accidents, and prevention of prevalent disease. These are the themes we are working. Some success and lessons themes just to share with you all. Fatherhood is a positive entrance door in health. It's a strategy and opportunity to introduce men to primary health services in the arena of care, health, and gender equity. Actually, I have been traveling around for the last 6 years to several places, and I'm convinced that it's not possible to get good indicators for human and for children if the men are not engaged. It's not possible because they are living there. They are in the place. They are living the community. How you can work with children and women and not work with men? It's not possible. So we have to work all together. It's very simple, very obvious. Well, we are some success, partnering with civil society organizations, UN, or the health coordinations. We are working with humans coordination, teenagers coordination. This is really important. The Ministry of Health, the platform of communication of Ministry of Health, they are working very hard with us in social networks. This is really important. And something that's really important that I want to finish my speak at this moment here. Despite all this information that men they have to work to protect and to promote humans and children's health, it's really important that we must learn how to direct our attention to men's specific health needs, recognize their rights, and clearly show that this is also positive to them and to everybody around them. This is really important. Thank you.
I think we'll take this opportunity to show a video from Brazil, developed specifically on this issue. Eduardo, would you like just to say one sentence about the video while I...
the first one is mine or from... Well, I show you now... After? I talked before or later? I'm going to share with you guys the national campaign for the men's health policy that was realized in 2009. This happened in the main TVs on Brazil during 2 months, and it was really interesting. We made a very big campaign with outdoors, with radio, with TV, and this is the TV clip that I would like to share with you.
São de homens.
Every 3 deaths of adults, 2 are men.
A cada 5 pessoas que morrem entre 20 e 30 anos, 4 são homens.
Of 5 people who die between the ages of 20 and 34 are men.
Homens vivem em média 7 anos menos que as mulheres.
Men live on average 7 years less than women.
Sabe por quê? Porque o homem não cuida da própria saúde.
Because men don't take care of their own health.
O homem que se cuida não perde o melhor da vida. Política nacional da saúde do homem.
Men who take care of their own health take advantage of the best things in life. Look for your health clinic.
Great. And let's just quickly show you a clip. Guy, if you could just say
Sure. This is a documentary done by PBS here in the U.S. that is on the effects of this initiative.
Great. And then just to say, after this clip, we're going to go straight to questions, so please get your questions ready. Those that are joining us through the webinar, please, if you haven't already posed your question, please do so now. And we're hoping that we can connect the technology so that those who are joining through the webinar can also speak those questions. So get ready to ask your question.
This was filmed in Rio, where the program that Eduardo talked about was one of the first places it was implemented.
It takes a lot more than group education and community campaigns to get the men of the favelas, or men anywhere, to buy into gender equality. To scale it up and make it sustainable, Promundo works extensively with the public health sector. With Promundo's input, the Brazilian Health Ministry has set up a protocol for fathers, starting well before the child is born. It's designed to engage fathers in the prenatal process so they bond with the baby while it is still in utero. At the same time, men are encouraged to get checkups for themselves, a rare moment for men.
In some critical ways, Brazil is way ahead of the United States and educated European countries in terms of integrating men into gender parity. And it starts right here in this maternity ward.
Very often involving health workers who, whenever a woman comes for a prenatal care exam, ask, why isn't your partner or your husband with you? Can we see you both next time? Let us do the ultrasound exam with both of you present and seeing the baby reflected on the ultrasound, listening to the heart of the baby beating and creating a bond even before the baby is born.
From that first visit, fathers attend checks with their wives and partners. They become actively involved with the pregnancy as opposed to being excluded. Traditional medical protocol kept the father in the waiting area while the mother gave birth in the delivery room. Fathers learn how to change diapers, feed the baby, sing to it, and build a healthy, non-violent relationship.
Traditionally, health services focus their attention on women and children, with a special emphasis on pregnancy. Men were not part of the equation. Yet as we move towards a more holistic approach, here in Brazil, we have the universal healthcare system, which is responsible for the health of all Brazilian citizens. We realize that we have to look at other dimensions, not only men's issues, but also other issues that concern women. It is beautiful to hear the feedback of men who take advantage of these services, of men who are in the delivery room, moved by this experience, since they can indeed experience it in its entirety, this very special moment, a moment full of emotion.
This father held the mother's hand as the baby was delivered by cesarean section. He was right there when the child was born, and after hospital staff cleaned up the baby and gave it oxygen, the newborn was presented to him before the mother. This woman delivered her baby naturally, as she had done with her prior children. This was the first time her husband was by her side.
It is painful, but it is also beautiful. I always wanted him by my side. For being his first time, he did a great job. He calmed me down a lot.
It creates a bond because I've seen what she went through, her struggle, the pain. It's a new closeness because I had never witnessed the birth of a child before. When I saw her giving birth to our son, yes, it's very emotional, a very special moment.
Great. Thank you. Let's open up the floor to those in the room, and then we have a roving mic here. You've had a lot of information. We'd love to get your contribution to the conversation. And just a reminder also that people can join us, as they have already been doing, through Twitter at #GenderSeminar.
I just wanted to remark that I noticed you even have suicide or homicide in your presentation. I was curious if you could speak a little bit to that, because, for instance, we know that suicide is very gendered, and one of the only areas consistently we see women with greater rates of death by suicide than men is rural China, which would seem to be contradictory to the conclusion that improving women's empowerment can result in at least all of these kinds of negative health consequences.
Great. Let's take a couple more questions. Any others in the room?
Thank you so much for your excellent presentations. My name is Joya Banerjee from Be the Change Group. I had a question regarding the replicability of both Promundo's programs and some of the other programs that have been discussed, as well as Sankhya Gender Justice, in both the Middle East and in India in particular. I think there's been a lot of recent attention given the gang rape and sexual violence in the news in both the South Asian and Middle Eastern context. And I wonder what challenges you would expect to encounter doing this type of work in that context. Thank you.
Great. Is there another question here? Do we have a question online? Great. Would the person online like to ask a question, or will you? Great, great.
There's a question.
So there's a question there from Peter Baker submitted.
The question from Peter Baker is, how can we get the WHO engaged with men's health on the policy level? So far they have seemed very reluctant.
Great. Are there any questions on Twitter?
There's not a question so much as a statement. Martin Todd from the Men's Health Forum from the UK said perhaps we need a global version of the Men's Health Forum, Men's Health Manifesto.
Great. So those are excellent set of questions. Can I turn over, perhaps, just in the order that that you're sitting? I'll turn to you first, Sarah. There was one specific one to you around the data, and then please feel free to add to any of the other questions.
Sure. So the question of suicide. When you look at the data that I presented, the top 10 conditions wouldn't have included suicide because it wouldn't be in the top 10 causes of death and disease or loss of salaries around the world. Where suicide might have been included was in the adolescent section, but in fact the only, from memory, the only figure in there that refers to violence, it's just a general violence figure, where what you saw was a ratio of about 4 times higher salary loss in young men compared to young women for violence in general. We had previously broken that figure down, so looking at whether that's interpersonal violence or self-harm. And so at a global level, it's very clear that the self-harm data are very much higher. Suicide rates are much, much higher in men, young men and adult men compared to women globally. The specifics of rural China, I mean, I must say I don't know the Chinese data. I would imagine that the Chinese data contributed quite a lot to the global data. So it's very hard to comment without knowing the specifics of it. You could argue, of course, that empowerment data will be different between rural and urban areas, and so perhaps what you actually need to look at there is suicide rates in rural compared to urban settings rather than just, I mean, in other words, you need to look at gender a bit more with an intersectionality lens rather than just a gender lens to see what's driving that. But the only reason suicide doesn't appear in the other data set is because it's not in the top 10 causes of salary loss globally.
Okay.
Probably the only question of mine to respond to is the one from WHO, that there's the French people that there's such reluctance to engage men more broadly.
Or there perhaps a reluctance to, in the context of global health, to look at the issue that we're having a conversation around.
So again, I think I can only, I would prefer to speak only from the perspective of international family planning, which is where I've been working and I'm more knowledgeable about. And I would think that there is a great deal of reluctance. And I think it goes back to the fact that we really, for decades, have built this field around women as consumers of reproductive health services, as the primary beneficiary. And it's hard to roll it back. I mean, we've now reinforced this reality that it is women's responsibility, that it's women's business. The services are set up for women, and so there's a lot that we would need to do differently. We don't even really understand, to a great extent, we don't expect men to have reproductive intentions, to have fertility intentions. We don't really understand where they're coming from or what they need or what they want, what the perspective is. It's not something that we measure. So there's a lot of information. I think that there's a mind shift that we as a community practice need to make to be able to really think about the needs of men as reproductive beings and in the context of sexual and reproductive health and family planning. And there's a lot of biases that we need to examine amongst ourselves as practitioners, demographers, policymakers, and so forth. All of these pieces, I think, are layers and layers that have brought us to where we are now in 2015 with pretty limited engagement of men. But I am an optimist, and I'd like to believe that we can undo it if we are much more intentional about it.
Thanks, Guy.
I'll start with the question of suicide because I think it brings up a health issue that we didn't talk near mental health in general. And just two data points that reflect very stark differences between the two places, but that the trend is the same. A study in the U.S. that found that about a third of adults report feeling lonely or alone. First place were single men, most likely to feel alone. Second place, very telling, was married women. Married women were more likely to report that they feel alone than unmarried women. One of the conclusions one can take from that study is that American men are not very good company to themselves nor to their partners. And I think that, that is partly a question of the undetected depression that we see in men. Certainly the suicide data we know about the lack of social networks. So that's one piece of data from the U.S. Now go to a very different place. Ramundo is doing a lot of work at the moment, coordinated by Kenny Slag, who's our regional director, in Eastern DRC, conflict affected. We've done quantitative, qualitative research, and now a mental health trauma-based initiative looking at the unaddressed post-traumatic stress trauma in the region. About 40% of men and women showing some factor, it's almost half in some cases, some factor of PTSD. Men are much less likely to report they have anybody that they talk to about it. And what happens to the men who don't find some source of social support? Far more likely to drink, far more likely to use violence against their partner, far more likely to cause both harm to others and harm to self. So I think also as we look at men's unaddressed mental health issues, is to think this is a huge burden on women in addition to what it means to men. So I think as we look at the data of the unaddressed health, the kind of undiagnosed trauma, men's poor coping skills, and depression is something that needs a big attention. The question about how does this apply to work in the Middle East and South Asia? We certainly do not propose any simplistic transportation of this work anywhere. The approaches that I was showing from Brazil reflect slides from 10 years ago in terms of just, as I said before, sort of acts of desperation, figuring out trial and error of what kinds of approaches work. The men's health sector that Eduardo heads up has been some 8-9 years in the making, and now finally kind of hitting its stride, very much embedded in gathering local data, listening to. So that the processes of change, we think there's some things that can be learned in the Middle East and in South Asia, but very much around gathering data about it, finding the gaps, learning, gathering more data, learning from that, and moving on. So anybody who says we'd come with the one solution, run away very quickly.
Great.
Well, now, acho que Gary, about suicide. Eu acho que tem uma questão delicada, que é a questão de você não trabalhar com normas sociais de gênero no campo da saúde mental.
The lack of working on gender norms within the mental health field.
O campo da saúde mental trabalha no campo do inconsciente, ele não trabalha com essa questão de trabalhar com papéis sociais. Então você não trabalha com estratificação de risco para suicídio.
Mental health works a lot at the psychic or the unconscious, so it's not looking as much at gender norms and social norms.
Então, uma das maiores invisibilidades, na medida que você não tem as necessidades dos homens superficiais reconhecidas, nem mesmo as profundas, isso se reflete nas altas taxas de suicídio masculino.
The fact that we have neither very good superficial information on men or very deeper information on men means that we're seeing
Então, muito importante, tem alguns tabus na sociedade da gente que a gente ainda passa no Brasil, que está um problema seríssimo, que é com a questão do suicídio e com a questão das drogas, que não são bem problematizadas e digeridas pelo sistema.
Particularly in the health sector, the two big taboos are suicide and substance use. We don't know the stigma around them. We don't go deeper, therefore they're not well addressed.
E eu acho que tem essa dificuldade, para finalizar, que é trabalhar com as enfermidades sociais, que o preconceito, o isolamento, são doenças sociais que são muito difíceis de serem trabalhadas e visibilizadas. O que a gente tem buscado no Brasil é de fato, ajudar os profissionais de saúde e os gestores a visibilizarem os homens, a incluírem os homens na lógica dos serviços que são ofertados.
I think that the health system in general has not been good at working with what he's calling social illnesses, so prejudice, loneliness, social isolation. Those are kind of, they're missing completely from the health system. And one of their biggest focuses is on making men visible and men's issues visible.
Great, thank you. We have time for a few more contributions. Are there any other contributions in the room? I think we can take one more, and I think we have a few online. We're short on time, so a request to please keep your question as brief as you can.
Now, the World Health Organization question, it was tied to mine. And mine is more directed not at the World Health Organization, but government. Our government's more into like conscripting young men into armies more than into their health. What can we do to really engage with our governments to make men's health a priority?
Great. Let's go to Twitter or join.me. There was a question I saw from Martin Todd on Twitter.
Yeah, there's another question from Peter Baker. First of all, a question, which is, why does the panel think that men's health is generally overlooked? After all, it's surely a problem in very plain sight. And then he has a statement just to say, a statement, I'm currently reviewing Ireland's national men's health policy, and it's clear that it's had a major impact despite a serious, lack of funding because of the recession. The lessons are clear for international actions too.
And I think there's a question here from Martin Todd, which is, what about the impact of working
What's the impact of working full-time? It's striking in the UK that primary care access equalises after retirement. For reference, in the UK, men are 61% of full-time workers and 72% are full-time self-employed.
Great. So we have three questions there, one around the role of governments, and I guess to some extent the same question as was asked earlier in relation to the WHO, and how do we get governments to look at this more. A question around why in general is men's health being overlooked, and the example of the Irish men's health policy was referenced, and then a question around the impacts of full-time work. Can we do an opposite order if you don't mind, starting with Eduardo? Okay, sure. Let's start with Gary.
The first one on, that I think you hit it precisely. Why do we spend so much time teaching men how to cause harm and not nearly enough on how to care for themselves and others? That question needs to be shouted many, many, many times over. It is ironic that some of the best men's health data in the U.S. is from the military. It is in the U.S., ironically, the place where we have what is called socialized medicine. And we have fantastic data, and we have wraparound services. I'm not at all questioning that women and men who have served in the armed forces need that, but it is telling that that's kind of the only place we get men in the health system in big, big ways, and the only place that we have something that looks like an integrated health system, including men's mental health. So someone should make some more noise about that as well. Why overlooked? I mean, the women's rights field has done a fantastic but still incomplete job of calling attention to issues, say maternal health, that were given very second-class status for a very long time. We're not done with it. So I think it's time to say, what can we learn from that? There hasn't been an equal sort of women and men marching for how do we get men to pay more attention to health. We're starting to do that, but I think we need to figure out ways that we lock arms together with our women's rights colleagues. I'd be really worried about a men's health movement that doesn't lock arms with women's health. Otherwise, we end up with these kind of very small identity pockets as opposed to really saying, this is about health for all. And we have to look at these gaps, and some of these gaps have to do with men. So I think we haven't done the creative advocacy we need to do. I really hope we can do it in a way that doesn't feel like it's us versus them, because we're all in it together. That's why my data point of men's ill health affects women. Women pick up the pieces on this. This needs to be both.
I couldn't agree with you more, Gary. I think that to the extent that we continue to think of the package of men's health as separate from our public health and the benefits to all, I think that we will continue to see this reluctance, because it seems as though it's completely separate and tangential concepts. So partly it's how we're talking about it. There needs to be a shift in how we talk about it. The fact that it's not detracting attention and resources from something else. It is complementary and it's a piece of what we have. And the question is how to build that piece in a way that's sensible and integrated. I think that this is definitely where our work with advocacy groups is very important. I think probably a piece of it is also econometric, to the extent that we can make the case with the costing or the benefits of this kind of work to our other investments in health will help convince government. And I'll just say very quickly, I think that we have some opportunities with current global policy efforts that might provide us with a platform to talk about this some more. In particular, I'm thinking about Family Planning 2020 initiatives, and I think potentially the SDGs. So let's think about that as well as a way to push the agenda.
Yes? You're going to go?
Gary, mais uma vez. Eu acho que tem bem rápido agora, tem uma questão delicada que, primeiro, a gente tem o paradoxo do poder masculino, que é o fato dos homens morrerem como heróis, não estarem em cargos de poder, mas não se privilegiarem em relação à sua saúde e morrerem como heróis.
So we've got this paradox, right, that men are in power, and that power, the kind of to be the hero and never back down, is also the cause of men's early death.
Eu não tenho uma visão romântica da inclusão dos homens nos serviços de saúde. Eu acho que uma questão que está se colocando que é a seguinte: os homens ainda são objetificados dentro do sistema, eles não são vistos ainda como sujeito de direitos. Agora tem uma questão econômica que é o seguinte: os homens eles entram no sistema pela média alta complexidade, em altas cirurgias, em altos procedimentos que geram muito dinheiro para muita gente.
There's a big economic question that men end up in the system when they need some more expensive and complex health care, surgery, etc. So one of the biggest costs in the health system is men's chronic health that they come later on.
Agora, os sistemas nacionais de saúde, eles estão começando a perceber que eles têm que investir em prevenção e promoção, porque eles não conseguem financiar a saúde de todos e de todas.
So one of the issues that the health system has to figure out how to invest in prevention, because there's not enough, if we wait until the end, there's not enough money left to provide care for chronic.
I just want to pick up on that very last point, because I think that to me that's actually the most important point. I think we need to start having a conversation that says health does not happen in the health system, whether you're a man or a woman. Health is driven by the social, political, commercial context in which we all live. The health system picks up the illnesses at the end. As government, we will never, ever be able to afford to treat all of the chronic illnesses that are waiting to hit every country in the world, from smoking, drinking, sugar, and road accidents. What we need to have is a conversation about how to address the determinants of illness that affect all of us. And I don't think the health system can do that. Ministries of health are very weak, generally, in low and middle income countries. You need to talk to the ILO and the trade organizations and the people who actually determine what makes us all sick.
Great. I think that's an excellent place to end. I think we've had a lot of great comments. I think the message from this morning's panel was that how do we go through this conference and become advocates that we do, and so I would strongly encourage you to do so. Thank you very much for joining us. I think we've heard, before you run off, I just want to say I think we've heard a great conversation around the importance of increasing the focus on global health, and that it's not just about the benefits for men, it's about the benefits for women, for children, for families, for everybody. So thank you very much indeed. Thanks to those who joined online and stayed with us despite some of the technical challenges. Thank you to the excellent panel. Thank you to Jenny and Victoria on the front row who were helping both with the technical issues. So if I can ask you to give a round of applause to the panelists for this conversation. Thank you. The conversation will be available if you want to listen to it again, if you enjoyed it so much. It will be available for podcast, so tune in to that. And yeah, and for those who are really keen, we can organise a separate, separate copies. You can sign copies. Thanks very much. Take care.